All right, so I figured with the ENT and eye topic that caustics would be a good one to talk about this week. In the past, I've always done this as like a chalk talk, but I actually made some slides since we're doing it remote this time. Um, so we'll talk about a basic definition of caustics. I'll review the different types of caustics, what the risk factors are for injury, how we evaluate these patients, how we manage these patients, and some special discussion of HF. Does anyone here think they can define a caustic? I think we all sort of have an intuitive understanding of what we mean when we say a caustic, but there's the actual definition of it. Anyone think they can do that? Kelsey?
Like a noxious stimuli.
Okay. Okay, but I think that that wouldn't really distinguish between physical injury, like a trauma, from a caustic, right? But I think you're definitely on the right track in that it's sort of something that's non-specific, right? So the way that we typically define it toxicologically is a substance that causes functional and histological injury on contact with tissues. So it doesn't have a specific, target receptor or something. This is basically non-specific injury on contact. And there's a number of different types of caustics, right? I think most of us typically think of acids and alkalis, but strong oxidizing and reducing agents, defatting agents, things like phenol are in that category. Can anyone think of some household acids that people might encounter?
Vinegar.
Okay, that's usually not going to be strong enough to cause a significant caustic injury, but so vinegar is acetic acid solution, and there are strong forms of acetic acid that are used in kind of commercial pickling. I think that sometimes in Korean community, we might see, people who are making kimchi might have a more concentrated acetic acid that potentially could cause an injury, but that's less common as a household acid.
Cement.
Okay, so usually cement is going to be an alkali. That's like Portland cement has lime in it, and that would be an alkali. That's something that like you'll see sometimes construction workers will get it in their boots or something, and they'll be kind of working all day, and then at the end of the day, they have a caustic injury in their feet. Um, so there's a lot more alkalis that people typically encounter than acids, and that's something specific to the United States because of our strong consumer product safety regulations that kind of keep a lot of acid products that are in other countries in people's homes out of people's homes here. But there are a few acids that are out there. The toilet duck that you use to clean the toilet is typically an acid, and it may be sulfuric acid. And so that's a pretty nasty one. Drain openers, most common drain openers that people are going to use are going to be alkalis. But the one that your super might bring, like an industrial kind of drain opener, might be an acid. Somebody in the chat said battery acid. That's another potential one. But alkalis are a lot more common, right? So there's a lot of household alkalis. What are some common ones that you might encounter?
Bleach.
So bleach is an alkali, and it's not the bleach. It's not the sodium hypochlorite that's actually the alkali, but bleach is inherently unstable. And if the solution's pH drops too low, it will start off-gassing chlorine gas. And so in order to prevent that from happening and preventing people from getting gassed with chlorine in their homes, they add sodium hydroxide to bleach to keep it stable and to prevent that from happening. So bleach actually has lye in it, and that's why it's an alkali. Now, household bleach is not typically concentrated enough to cause significant caustic injury. It's obviously you'd rather somebody didn't drink it, but it's pretty uncommon for people to have more than a grade 1 injury from bleach alone, and we'll talk about the grades of injury later on. Now, when you start to get into industrial products that somebody might use in the workplace, then all bets are off. They may be much more concentrated, and sometimes, and that's a problem that occurs frequently because people know that industrial product that they use at work is better, right? It works really well because it's more concentrated, and so people will sometimes bring those products home. And what do they bring it home in? They bring it home in the Snapple bottle or the Gatorade bottle or something, and then it gets left out on the counter, and somebody may not be aware that that's what's in it and takes a swig of it, or maybe even the person who brought it home takes a swig of it. So other common alkalis that you may see in the home, oven cleaners, drain openers, I already mentioned, button batteries have alkali in them. So a lot of potential options there for things that can cause harm that are alkali products in the home. One that we may see in our patient population is hair relaxers or hair straighteners. May contain alkalis. They may be sodium hydroxide, or some of them will be sold as no lye. And no lye is kind of a lie in that it's true. It's not sodium hydroxide, which is lye, but it'll just contain another strong alkali like lithium hydroxide. So it's kind of deceiving in a way in that it's not lye itself, but it's an equally harmful caustic. So when we're thinking about things that predict injury, what is somebody potentially going to get a significant exposure from these? The things that go into that are the concentration, the pH of the substance, and then this concept of titratable acid reserve or titratable alkaline reserve. And that basically is how much of the other one it takes to bring it to pH 7. So that kind of combines both the concentration and the pH of the substance that the person was exposed to. The duration of contact is also going to play a role, and then intent. All right, and this in some ways is counterintuitive, but people who are taking it with the intent of self-harm, who are trying to commit suicide with the product, are much more likely to have a significant injury than the person who has an unintentional injury. And in terms of unintentional, this is the vast majority of pediatric exposures.
Recording in progress.
So when people have a pediatric exposure, I think somebody's, yeah, there we go. All right, so when pediatric exposures are typically going to be toddlers that are exploring their environment, and one of these products will be left where they can reach it, and they're not trying to harm themselves, but they wind up getting some on them themselves. So that's different than the adult who's trying to commit suicide and is even though it may cause pain as they're trying to swallow this thing, they're going to continue to do it. And so there's a lot of data on unintentional pediatric exposures, and I'm going to show some of that for you. There's a lot less on intentional adult exposures, and also on unintentional adult exposures, which do occur. And it's mostly the scenario that I talked about earlier with the patient bringing home an industrial product for use in the home in a bottle that's not the original container that it came in. So when we see a patient clinically, what are we going to look for? Well, they may have oropharyngeal lesions. They may have dribble burns, especially on pediatric patients. You may see kind of dribbles of a product on their skin externally. And we may see airway issues, right? They potentially can have significant injury to the airway, and these can be really challenging to manage. Mark Sue, who's formerly an attending at Kings County, and who's currently the director of the Poison Center, I remember he had a lye ingestion in the old C1, what is now CCT, and that patient, when they went to intubate the patient and they put in the laryngoscope, the tongue basically came out of the mouth onto the bed next to them. So you can imagine these are challenging airways. These are things where you definitely want to have your fiber optic involved and potentially anesthesia on board, because they definitely may not have normal airway anatomy. So we may also see potentially aspiration of these, and then they can have compromise of their gas exchange in their lungs. They can have lung injury. And then you can have perforations in the mediastinum. You can have perforations anywhere along the GI tract. And that can be particularly difficult to kind of detect, because when we're used to thinking about perforations in the abdomen, we are used to thinking about a process that is from an infection, right? So an appendicitis or a diverticulitis or something like that, that perforates and pus spills out into the abdomen and causes irritation, and patients get peritonitis. But typically, when you have a caustic injury causing perforation in the abdomen, they don't get that immediate peritonitis that you typically expect from other causes of perforation. And that can be sometimes challenging when you have surgeons come and evaluate a patient for potential perforation from a caustic injury, because their abdominal exam is not going to be what they're expecting for a patient with perforation. Now, here I've been mostly talking about ingestions, but remember that caustics can also cause injuries in other places. You can have caustic injuries to the eye. You can have caustic injuries to the skin. And these are in some ways easier to manage, and we'll talk about why that is. Now, I think that we all learned in medical school about the difference of between the caustic injury to tissues from acids compared to bases, right? And you may be familiar or may have somewhere in the recesses of your memory coagulative necrosis versus liquefactive necrosis, and potentially the idea that you may get deeper penetration of an alkali than an acid, and that's true, and that's especially relevant in the eye, where you're more likely to have a perforation of the eye when you have an alkali product. But which one of these do you think is more likely to cause lethality, all other things being equal, in terms of concentration and extremes of pH? So I think most people would probably expect the alkali, right, because of that liquefactive necrosis. But the main point I wanted to bring home is that strong acids, you can actually absorb the acid and get a systemic acidosis from that. So you can get systemic toxicity in a way that you don't get from alkalis. You don't absorb the alkali and get an alkalosis from it. So you can get acidosis from local injury to the tissues, but you can also get acidosis from the acid itself by actually absorbing it through the GI tract. And that's why potentially acid ingestions are going to be more dangerous. So when we're going to evaluate these patients, then we're going to typically get our labs on them, and that'll include a blood gas with a lactate, because lactic acidosis is pretty common from the local tissue injury, PT-PTT, and a comp. X-rays to look for signs of perforation, so an upright chest, a KUB. If the patient has any sign of airway injury, then you're going to want ENT to scope them early on. And then I'm going to talk about the role of GI endoscopy, basically EGD, in these patients. If you do get GI endoscopy, it's important that it's in the first 12 to 24 hours. It's not something that necessarily has to be done immediately when the patient, if it's in the middle of the night and you're in CCT, they don't have to come in the middle of the night to do it, but it should be done within the first 24 hours, because if you wait longer than that, as the tissue is starting to heal and the injury is progressing, you're more likely to get a perforation if you wait longer than 24 hours. Whereas if you do it early on, that's less likely to occur. Now, if there's any concern for perforation, CT can be valuable, and this is something that, as I said, the clinical exam can be misleading. So if you see a lot of air under the diaphragm on your upright chest, then that's a no-brainer. But if you have a patient with a really severe caustic injury, you should have a high suspicion for a perforation, and potentially would think about getting a CT, even if you didn't see that air on the X-ray. So in terms of endoscopy, here it's going to really, you have to separate out the adult intentional and pediatric unintentional exposures. Because if somebody intended to try to hurt themselves in taking a caustic, all of those patients get scope because they may try to mask their degree of injury, and the exam just is not reliable enough to exclude an injury. So anyone who intentionally ingests a caustic is going to need a GI scope. And we'll talk about why that's important. Um, but for pediatrics, getting a scope is kind of a big deal, right? Especially on the younger ones. The anesthesia is going to be a bigger deal. You need to have a pediatric GI, which not every place does. And so you really want to try to be a little bit selective about which patients get endoscopy. And so there have been a number of attempts to do this. So Previtera did a study looking at the predictive value of lesions in the mouth, cheeks, lips, and oropharynx, and basically found that if you see lesions in the mouth, lips, cheeks, then the patient is much more likely to have an injury, but the absence of those lesions is just not good enough to exclude an injury. So the person, it's kind of counterintuitive, right? You'd think that you couldn't have injury deeper in your esophagus without having an injury somewhere in your mouth, right? Because it has to pass through your mouth first, but that's not empirically what's been observed. And so, a patient can potentially have a significant injury in their esophagus, even if you don't see any injuries on their face or in their oral cavity. This study by Ellen Crane that was done up at Jacobi looked at clinical symptoms as predictors of injury, and she looked at the triad of symptoms: vomiting, drooling, and stridor. And what she found is that if you have any two of those, then you're likely to have an injury. If you had none or one, then you were not likely to have an injury. And so those patients potentially wouldn't need endoscopy. Now, nobody in her study had stridor alone. So stridor alone is typically considered to be enough by itself to warrant endoscopy. But vomiting and drooling, or either one of those and stridor, is a clear indication for endoscopy. So who do we scope? Anyone with an intentional ingestion, anyone with stridor, anyone with a combination of vomiting and drooling. If they have persistent pain, and that was not directly studied in any of these, I think a lot of people would consider that an indication to scope as well, or if they're not tolerating PO. But if they're tolerating PO, they're asymptomatic a few hours after the ingestion, then potentially they don't need any further evaluation. So what are we looking for when we do endoscopy? We're going to be looking for these lesions, right? So a grade 1 is a very superficial lesion. It's basically kind of like a first-degree burn that you would see from a thermal injury. And the grade 2 is separated into two kinds, A and B. So grade 2 is like a second-degree burn, a partial thickness burn, and the 2A is linear lesions, and 2B is circumferential lesions, lesions that go all the way around the tube that you're looking at. The main reason that this is important is because of their prognosis for long-term complications from caustic ingestions. And then grade 3 is a full thickness injury. So that's kind of like an eschar looking thing. Now, sometimes it can be difficult to tell from a scope whether you have a full thickness injury that has led to a perforation, right? Because you can have a grade 3 injury that didn't perf. When we do an endoscopy, you can see the inside of the GI tract. You can't see the other side of the GI tract, which is what you would really need to know for sure to see whether it completely penetrated through the structure. If you do have a full thickness injury, these pretty much always are going to go on to be pretty catastrophic and are going to need aggressive surgical treatment. But the 2As and 2Bs are important to distinguish because the 2Bs are much more likely to lead to our most important complication, which is stricture of the GI tract. And so potentially that may affect how we're going to manage these, knowing whether they're at risk for stricture or not. So in terms of management, there's a number of strategies that you could potentially conceive of, right? You can try to dilute it. Um, and if you have an injury on the skin or on the eye, there's really no limit to how much you can dilute it. And so that's a effective strategy there, right? So if you spill an acid on your arm, you can just keep pouring water on it until it's diluted enough that it's not going to harm you. Or if you get an acid or an alkali on your eye, you can irrigate it until the pH gets to 7. So those are important strategies for those types of injuries. But for an ingestion, it becomes problematic because pH, remember, is a logarithmic scale. So to change the pH by 1 is a 10-fold dilution. To change it by 2 is a 100-fold dilution, and it just is challenging to give enough volume to be able to make a significant impact through dilution in the GI tract. And especially if you have a patient where you don't know whether there's a perforation or somebody who's at risk of perforation, starting to put large volumes into the GI tract potentially is going to be problematic. So dilution is a good strategy for external injuries, but not one for internal injuries. Neutralization is another thing that you could conceive of that would be a strategy, but that really is never indicated. Neutralization is an exothermic process, and you have the potential to add a thermal injury on top of the caustic injury. So you never want to try to neutralize, and especially if you're thinking about an ingestion, neutralization is not going to be a strategy that's going to be effective when you consider that it's not going to potentially splash exactly in the same spots that the other one did on the way down as the person was swallowing it. Activated charcoal is typically contraindicated in caustic ingestions. First of all, because it's not going to help. Right, the injury is done pretty much on contact. It's a very rapid injury, and the charcoal also is going to obscure what the endoscopist potentially is going to be looking for if the patient winds up getting endoscopy, right? If you put this black material all over the GI tract, it's going to be really tough for them to tell whether there's any kind of injury there. If there's any concern for perforation, you want to get surgery involved early because aggressive surgical treatment is going to be critical if the patient has a full thickness injury. And then we consider steroids. And the literature on steroids has been a lot of back and forth over the years. Part of the problem is that some of the studies are done in other countries where they have a lot more acid exposures, whereas we predominantly have alkali exposures in the US. And again, I'm going to be talking mostly about steroids in their role in preventing strictures for patients who are at risk for strictures. In patients who have airway injury, typically it's going to be recommended to give dexamethasone for those patients in order to decrease the edema in the airway. But in terms of for more distal injuries in the gastrointestinal tract, the role of steroids there is really preventing strictures from that inflammatory response to the injury. So, sorry, I have this picture here of a strategy that you can use. This is what we used to do. If you don't have Morgan lenses around, you can use the nasal cannula, oxygen tubing, and hook it up to an IV bag and put that nasal cannula over the bridge of the nose, and that can irrigate the eyes. And that may be a good strategy if you have a concern for a potential full thickness injury in the eye, where putting a Morgan lens in may be a problem in terms of causing injury to the eye on top of the caustic injury. So there's a potential strategy. Morgan lens is reasonable if you're not suspecting perforation, but if you have a less severe injury, then you could use it. Otherwise, if it's a more severe injury to the eye, the nasal cannula is probably safer than putting a Morgan lens onto the eye. So in terms of looking at steroids, this is probably the best study. And basically what this study found is that giving a short course of high-dose methylprednisolone will decrease the risk of strictures, specifically in patients with 2B injuries on endoscopy. And this is part of why getting endoscopy early is, and when I say early, I mean within the first 24 hours, not necessarily in the ED during the initial presentation. But why it's important to get GI on board early for patients who meet criteria for a scope, because this decision making about steroids is going to be really important. Um, Now, there is a systematic review and meta-analysis of a lot of other studies that looked at steroids in these kinds of injuries. And the problem with that systematic review is that it includes a lot of patients that have either grade 1 injuries where we're not really worried about getting strictures in the first place, or grade 3 injuries where we know they're going to go on to do badly. And it's not focusing on the patients that are most likely to benefit, which are these 2Bs, the circumferential partial thickness injuries that can go on to form strictures, but are probably unlikely to perforate. Okay, so you have a few minutes to talk about HF, and it's usually better to say HF than hydrofluoric acid because people hear hydrofluoric and they may think hydrochloric. And when I say HF and fluorides, there are other compounds that are very similar to HF in their clinical effects. A common one would be ammonium bifluoride. So we can consider them together. So this was an incident that occurred in 1996. Somebody had discarded some vials or some cans, I think, of HF, concentrated HF, and the sanitation workers had thrown it into the truck. It burst and sprayed them, and they got some immediate caustic effect, and 3 of them went on to die. So this just shows how severe these potential injuries can be. And the important thing about HF is it's more of a poison and less of a caustic. And I'll talk about why that is in a moment. So HF comes up a lot. There are some key words that should make you think about it and suspicious about HF. The biggest one for your board exam or your shelf exam is glass edging. That's a common one that they love to ask about. But making microchips, electroplating, rust removal, porcelain cleaner, lumbar treatment, toothpaste and mouthwash, enamel industries are other potential sources. Here in Brooklyn, graffiti remover and brick cleaner is one that you're likely to see. Those patients, the HF solutions are used for removing graffiti from walls. And the HF, the way that the patient's going to present depends a lot on the concentration of the HF. Because if you have a highly concentrated HF, the patient may have some immediate caustic injury. And you should be extremely worried about those patients. But much more common is people working with a lower concentration solution. And a common one that we're likely to encounter is navel jelly. That's actually a product that you can buy for household use. And when you get these products that are in the 10% or less range of HF, they typically don't cause any injury initially, and they don't cause pain on contact. And it's only 24 hours later that you really start to get an appearance, something like this. So when you get somebody who is using a product and then has this delayed presentation, that should really raise your suspicion of HF or an HF-like product. And I should mention ammonium bifluoride. I didn't mention it with the keywords here, but that product, and we had a patient like this in CCT a few years ago, is a product that's commonly found in wheel cleaners. So the patient that I had taken home their wheel cleaner from work and wound up ingesting it unintentionally. So in terms of taking care of these patients, initially irrigation, if it's a skin exposure, calcium gluconate gel topical. For a patient like the one here, you can put calcium gluconate gel, which is basically you can mix calcium gluconate and Surgilube and put it into a glove and have the patient put their hand in it. And that basically can help draw out the fluoride. And I should mention, in terms of the clinical manifestations, in terms of the tissue injury, what you're seeing here is the fluoride penetrates deep into the tissue, binds up calcium, and makes fluoroapatite crystals that cause all this pain. So drawing the fluoride out with another source of calcium is going to potentially prevent this injury. Patients can also, because of the fluoride binding to calcium, can get systemic hypocalcemia, and they can also get hyperkalemia because of electrolyte shifts from that. So in terms of managing the local complications, local calcium gluconate gel we talked about, you can put in an A line and give calcium gluconate into the A line. It should be on the same side as the injury, and the A line should be placed somewhere more proximal than the injury so that when you're infusing it into the artery, it's going directly to the injured tissue. And giving supplemental calcium to patients who are hypocalcemic is also going to be really important. And that's typically a systemic manifestation from a severe exposure. If patients have an inhalation injury, then you can actually nebulize calcium gluconate as well. So really, these are really serious injuries. The local caustic effect is a small part of it, but the systemic hypocalcemia is the thing that is more likely to kill them, and potentially hyperkalemia. So just to sum up, caustics cause damage to tissues on contact. Remember that acids are potentially more lethal than bases because of their systemic acidosis that they cause, although the bases are more likely to cause a more penetrating local injury. People who need scopes are people with intentional ingestions, stridor alone, or vomiting and drooling, or if they're not tolerating PO or have persistent pain. Dilution is a good strategy for eyes and skin, but doesn't really work for ingestions. There's no role for neutralization or activated charcoal. Think about endoscopy early in patients who meet criteria, because those patients may benefit from steroids if they have a grade 2B injury. In patients who have HF injuries, then you want to remember to give calcium systemically if they're hypocalcemic, treat hyperkalemia if it occurs. And calcium can also help treat the local injury, either with topical calcium gluconate gel or with intraarterial calcium gluconate. And any questions?